Hi everyone, this is Dr. Raman from the Psychiatrist channel. Welcome to the channel and this very first episode of the Psychiatrist podcast. Episode 1 with Dr. Garrett Rossi, recently graduated attending psychiatrist who also creates mental health content on the Shrinks and Sneakers YouTube channel. Please like, comment, share, and subscribe for more content. Enjoy the show. Hi everyone, this is Raman coming from Psychiatrist. On our very first podcast episode, we have the pleasure of being joined by Dr. Garrett Rossi, who is an inpatient psychiatrist in the United States, and he also has been running the Shrinks and Sneakers YouTube channel, which is a great resource and something that I have personally been contributing many comments on. So hopefully that's not too overwhelming, but why don't you give us a short introduction about yourself?
Sure. Hey, Raman. So it's a pleasure to be on here and have this opportunity to talk to you for sure. I think it's always good getting your comments too. It gives me an opportunity to think things through because a lot of times as an attending, as a trainee, a resident, you need to go through that process of like really digging deep into the thoughts and saying like, okay, does this make sense? And what I'm saying, do I have the depth of knowledge behind it to really give good answers and good explanations? So I appreciate those things. So yeah, so like you said, my name is Dr. Garrett Rossi. I was previously a PGY for psychiatry resident when I first started talking about all of these things on YouTube, and now I'm currently an attending psychiatrist at Atlantic Care Regional Medical Center in New Jersey. And it's been a long journey for me. Started my medical school training at St. George's University, which is maybe known better as the St. George's University, is kind of infamous in the Caribbean as being a good place to train, but also a difficult place to train. And we could always chat about that if anyone is interested in hearing more about that experience and what that's like.
For sure. And I think a big part of our conversation today will be navigating the training process. I was an unmatched grad last year, so I definitely have had my own difficulties going through those things. So a lot of the focus will be both on the wonders and our own specific interests in psychiatry, but also kind of navigating our own unique journeys as well. I guess to start off, what made you interested in medicine and what made you interested in psychiatry? And did one come before the other, or what does it?
Well, I mean, this is a long story, so I don't know how much time we have to discuss it, but
I trust your time management as the attending in the room.
okay, all right, my time management. Yeah, I like to take my time, but it's difficult. For me, I was never really meant to be in medicine. At least I didn't think of myself that way. Growing up early on in like grade school, I had actually got diagnosed with a learning disability. It kind of set my whole academic career up for not much, right? I mean, people kind of identified me at that point. I wasn't going to be identified as one of the gifted and talented students in the class. So opportunities to learn and grow academically weren't really there for me, and quite honestly, I wasn't really interested for most of my schooling, even through high school. But I planned in college to be a police officer. That was ultimately my goal. I figured like police work in the United States is pretty good job. It pays fairly well, and I was kind of queued up to do that. And so I was applying, taking some of the tests and all those things, but I wasn't really like fully committed to it. And I always had in the back of my mind, maybe I could do more with my life. Maybe if I tried again at college, like I'd have an opportunity to go back and do better. And ultimately that was kind of what led me back to school, was the fact that I felt like I always had a passion and interest in science. I just didn't feel like I was appropriate for that position, or maybe like I was a good candidate for it. So a lot of it was me convincing myself that I had the ability to go through it. And that led me back to, and I started from the bottom. So I started at community college. I went all the way from a community program to a four-year university, and then from four-year university on to eventually medical school at St. George's. But none of those things were easy, and none of them were very linear. So
yeah, and I can imagine that's kind of an unconventional path and something that's kind of so high grades in high school, high grades in university, and then kind of on the track. So there wasn't necessarily that many people that could kind of guide you at each juncture, right?
Yeah, I mean, that's another great point because it depends a lot on your background. My background, my family are all blue collar workers. Like nobody went to college in my family. Certainly nobody studied medicine in my family. So for me to learn all those things, and at the time I was going through it, I don't think we had as much on the internet as we have now.
True.
There's so many resources, right? You could
Yeah,
just click,
forums
you
and
can
all
just
that.
Google it. Yeah. I mean, there's tons of people telling you kind of how to build an application for medical school, right? Which was something I
Hmm.
had no idea how to do. I was like, I had no clue, really. So I had the grades, I had like a good MCAT score, but I lacked those other things that, the medical schools are looking for, the extracurricular activities, the volunteer experiences, the other things that they want. So yeah, with limited guidance and kind of blue collar background, it wasn't easy to make that jump from even university level to medical school level. And I think you're right too in stating that you're always a little bit disadvantaged when you're doing a non-traditional pattern. I think it's always better if you do well in high school and then you go to college and you do well and you move on to med school and residency and everything. So it's tough.
Definitely. And kind of what was that? Did you have kind of that romantic eureka moment that kind of put you to say, okay, I'm doing well in school, so maybe medicine's on the table? Or
Yeah, it was kind of weird. What really like interested me was actually like a community college biology one course that kind of got me really excited about science. And I just had a great professor and he really kind of guided me through everything. He helped me to, understand things, but I was really doing well in the course. I just like was absorbing the information. I was performing well on all the exams and in the labs, and it just kind of spoke to me at that point. And I really like took it as a challenge because a lot of the kids that were like in criminal justice or other types of majors were like, oh, bio one, it's really hard. It's like a really tough course. You got to be prepared, and that like motivated me too because I was like, I think I'm good enough. I think I'm smart enough. I'm going to come in here and kind of crush this thing. And that's exactly what I did. And then it just kind of took off from there. So it went from bio one, to my chemistries and my organic chemistries and my physics courses. And like, I really enjoyed, quite honestly, every one of those things, including organic chemistry, which is unusual for
wow,
pre-med.
and let alone a psychiatrist too, right?
Right. I mean, I just like there's something about drawing all the reactions out and like going through that process and working with the models that just really spoke to me. So honestly, after completed the 2 years of community college, I wasn't sure really like was I going to go PhD level like in biochemistry or was I going to go medicine? But I did a little bit of like I did bench research during my undergrad, so I just like wasn't really into that lifestyle of working at the bench and constantly needing to publish. I'm sure you've had that experience as well. I mean, almost everybody who goes into medicine has done some bench
Yeah,
research work.
definitely. And I think that's important that you kind of got your feet wet and then you kind of see, because I think in research, especially in medical school and undergrad, where it's kind of like a means to an end for a lot of people to just check that box. But as someone that's genuinely interested in the science and the kind of theory behind it, were you able to put that kind of immediate lifestyle on the back burner and think, okay, but as the PI, my life would be a lot different? Or was it kind of, this is definitely not the path right away?
Well, I mean, I definitely saw the benefits of being the PI, but it's almost like clinical research for us, right? And you'll see this as you're going through the residency process. Um, the people who are primarily researchers have sort of a publish or perish,
Yeah.
mentality, right? You got
Mhm.
to keep publishing, and not only do you need to publish, but you need to publish in very relevant journals, right? You want to get things in the Journal of the American Medical Association or the APA's Green Journal. You want to
Mhm.
be in those bigger journals that are going to keep your research relevant, and it can be really hard to do that. And we can certainly talk a little bit about research within psychiatry as well, because
Yeah.
I feel like there's levels to it, right? And not every program has access to like amazing research. Like my program that I trained at personally, it did not have like we weren't going to have like randomized controlled trials on the latest drug that we were
Yeah.
going to publish on. So I had to do more of literature reviews, case reports, meta analyses, things that maybe are not quite as, I guess, prestigious of research experiences, but
Mhm.
you know, you'll find what your program has to offer.
Definitely, and kind of work within those bounds. So I guess that interest in science, kind of from the college days, that's continued to permeate in your life through your research, an interest in that within psychiatry, the psychopharm kind of thing.
Yeah, yeah, for sure. I mean, like I said, I kind of knew I didn't want to do bench at that point. Even as a PI, I thought it was a little more than I was interested in doing, and I always wanted to work with people. And
Mhm.
so the only way I was going to be able to communicate with people and have that kind of life, I thought was through medicine. Um, so that's where I made that decision, basically to shift gears and move into the medical field. But again, had no idea how to get into it. To be completely honest, probably would have been easier to get a PhD position than it would have to get a medical school spot.
For sure. And I guess how did you come across St. George's? Did you apply in the States first?
Yeah, so another kind of problem that I had was, again, I didn't know like how many schools to apply to and how to get my
Yeah,
application
the
out there.
hidden curriculum.
Yeah, totally applied to like maybe like 10 schools, all on the East Coast, like between New York, New Jersey, Pennsylvania type of thing. I didn't apply broadly, which is, I think that's a good recommendation for
Yeah.
medical school as well as residency, to be honest. Because you're only doing it one time in most cases. You're going to apply to, let's say you're applying to residencies, you might as well apply to all the programs or majority of the programs, because you don't know what's going to come back when you set your application out there. So I made that mistake with the medical schools, but I also didn't apply to the DO programs either. I
Hmm.
applied only to MD programs, which are notoriously a little more difficult. I think that in this, at least within the states, changes somewhat between the years. It was previously like the USMD held like sort of the most prestige within residency training programs. Then the Caribbean MD actually was second, I would say.
Hmm.
And more recently, though, that's flip flopped with the DO program. So I think the USDO is a better option than the Caribbean MD if you're not too particular about being a DO versus an MD.
Yeah, I remember when I was looking through, because it took me quite a few application cycles to get in here in Canada as well. So I was kind of looking into the States options, looking into kind of the UK options, looking into the Caribbean schools as well. And there's a lot of kind of, because there's so much kind of the shroud of the truth. So there's just students talking to each other like, oh, I would rather do this than that. And you can't really take it at face value, right?
I think for everybody it's an individual decision. I personally believe that, having gone through my experience with the Caribbean school and even the application process within the United States, I think it's always better if you can go to a program within the United States. I
Mm-hmm.
think if you can get into an MD or DO program there, that's the preferred option. If you find yourself in a position like I did, where basically my opportunities were either take a year off and try and build my application up, which
Mm-hmm.
offered no guarantees,
Yeah.
or go to the Caribbean school, which was offering me a guaranteed spot, right there in that moment. And
Mm-hmm.
so for me, it was kind of like I was getting older. I had already wasted a few years. I had already wasted about 4 or 5 years of my life working and kind of not sure what I wanted to do type of thing, before I finally got serious about going back to college and figuring everything out.
Mm-hmm.
So that was putting me already at a disadvantage. But I think, yeah, if you can get into a program in Canada or in the US, let's say, that's a preferred method. And then if you have to go to the Caribbean school, it is good. It will give you what you need. But there's some challenges there that I think, like you said, people talk about, but it's not 100% known until you get there and you really see what it's like.
Exactly. And I think you touched on this a little bit earlier, and I'm not sure how kind of the new, not to get too kind of wrapped up in the situation in the States, but kind of the step one pass fail, and how that used to be the really, from my understanding, the make it or break it kind of thing for Caribbean schools, right?
Yeah, so Caribbean school like St. George's really prides itself on USMLE scores, because one of the ways that you could distinguish yourself from a US applicant basically is to be that much better than them on your step scores.
Yeah.
And that is the mentality. I mean, they basically tell you that. I remember sitting in like some of the basically they were like, I guess, courses on how to, what you need to do to get your residency application ready. And one of the things that they talked a lot about was that, you need to be scoring, like if you want general surgery, you need to be scoring that much higher, the X number of points higher than the average US applicant who's going to be, shooting for the same position in general surgery. So the more competitive specialties where, it's a little more difficult to get in, you had to, but it held true for everything really. I think there was a lot of pride on not only first time pass rates but also people scoring that much better than U.S. students. So it's always in my mind like I better score better than these people or else I'm not getting a position.
That's true, and it is kind of. I'm sure people who matriculated to kind of more competitive spots would then become like, point people for the hopefuls in earlier classes. Like, did you have a class cohesion like that, kind of the underdog banding together?
So for not being a very good student in high school,
Yeah.
I actually was a great college student and a really great medical student. So like my first 2 years, we don't have the traditional, I forget what the U.S. Honor Society is, but we had something called Alpha, which was IEA, and that was like our international honor society. So I was in that group, and I would say like every year, we would have someone that scored like a 270 on USMLE step one. So like we had like some really like savage people there.
Yeah.
And I think it was like underrepresented in a way. But even that person that scored the 270, again, that I think coming from the Caribbean school, you're a little bit disadvantaged. So it was difficult to match people. We barely match anybody to orthopedics or neurosurgery. I mean, we've had a few here and there, but when you look at the vast majority of people that come out of the Caribbean school, it's, family med, psychiatry, emergency med, general surgery, kind of like your lower and mid-tier specialties.
Yeah, I actually heard of one gentleman who applied for psych and backed up with internal. And it sounds like kind of those mid-competitive specialties kind of year by year, they change up, eh?
Right. My advice to anyone who's applying to residency, and like if you really love psychiatry, let's say like we do, you just apply to psychiatry. You don't back it up with anything. People know when you're playing games, and it's best to just be upfront and honest. Like if you really want psych, just apply to the psych programs. If you're a good candidate, you're going to get your opportunity. I think that's that. Like as long as you have a good application, for the most part, decent scores and everything, and decent grades through med school, the right type of letters of recommendation. And a lot of the times I'll tell people like it's the personal connections that they make. I think one of the biggest benefits is that like if there's a program you really want to be at, you make personal connections with especially the residents at that program, because they're going to have a lot of say in whether or not they choose you as one of their candidates. If they like you, if they vibe with you, you're you're way more likely to get a spot than someone who has a great paper application and has kind of like a blah personality.
Yeah, or even worse, like kind of a chip on their shoulder, kind of one-upping the residents at the time. I think one senior resident on my CTU rotation once put it pretty well to me that kind of all you want to do is whenever they choose the residents, it's kind of like a room, and this is all kind of hearsay, so not based on fact, but it's basically the residents and the team that are on the selection committee will kind of put up your photo, and people can really shoot you down if they've had a negative experience with you, but they can also be vouch for you if you're there. So you kind of want a few people at that program that you're really hoping for to have had a positive experience and to go to bat for you. You don't have to kind of have done so much for them, but at least enough that they'll remember you, right? Positive.
Right. I mean, absolutely. And I think, if you get a chance to rotate at those locations and you stand out a little bit as a student, it's really helpful. I mean, you mentioned the chip on your shoulder now. Now, certainly I carried a little bit of a chip on my shoulder because of my background. I always felt like a need to be a little, like I said, always be a little bit better, always push a little harder than maybe other people. And you're right, it works for and against you, and you got to be careful how you display it, I guess, or how you use it.
Yeah. I think maybe I should have said arrogance outright rather than chip on the shoulder, because I also had something like that.
Yeah. I mean, I feel like if you've ever been in a situation like your situation, like my situation,
Mhm.
where you kind of feel like you're capable, you're a good candidate, and you just don't get that opportunity for one reason or another, it does kind of put you in that moment where you're like, well, like I'm gonna show these people. It might be a little petty, I would say it's a little petty, but if it's motivating and it works for you, then it's not a bad thing, right?
Yeah,
To come from that mindset.
exactly. And I think you hit the nail on the head in terms of if it's motivating, if that's what drives you, that's one thing, but it shouldn't necessarily exude from you all the time, right?
Right. And you're still going to get along with your colleagues. You're still going to have to work with these people, right? And
Yeah.
I think a lot of times, getting back to sort of residents choosing you as a candidate, to become a new intern there, they're looking for someone that they can work with, especially the second years that are going to be working directly with you. I mean, I'm not sure exactly in Canada how it works. But I knew in the States here when I trained, it was a lot of the times the first and second years were together, and then like sort of the third and fourths were together because they were doing different types of rotations, a lot more outpatient in your third and fourth years, and a lot more of the inpatient consult ED in the first and second year.
Exactly. In Canada, it's pretty similar to the States, I think, but you can correct me if I'm wrong. We do first year is kind of a rotating internship, but we have maybe kind of select things that are off service. So I think we have internal medicine, depending on the program, maybe neurology, maybe neuroimaging, and family medicine as well. Then second year, we do inpatient for 6 months and outpatient for 6 months. And then third year is geri and child, geriatrics and child and adolescent psychiatry. And then fourth year, I believe, is some CL and some other kind of areas. And fifth year, you can kind of, well, yeah, we do 5 years here. And then you can bridge that with a fellowship, or you can kind of just do electives and kind of build your knowledge base in that way.
Yeah, I mean, certainly that sounds pretty similar for sure. The first year does involve about 6 months worth of neurology and internal medicine, sort of like three, I think it was like, yeah, 3 or 4 months. I think it's 4 months of internal, and that involved like floor medicine, outpatient internal medicine, and then also a couple months of neuro, 2 months of neurology, basically. And then that for me was mostly inpatient with a little bit of outpatient neuro, but mostly like your bread and butter neurology stuff that would like roll into the medical floor. So it sounds about the same. I think personally, this is my opinion, and some people share it. I think psychiatry could probably be done in 3 years. I feel like the fourth year in the states here, at least, it's all electives.
Oh,
So it's
okay.
by that point you've kind of done all the necessary requirements to sit for the boards. Like you've had your
Mhm.
geriatric, you've had your child, you've had your inpatient, outpatient stuff done. You're good. You
Mhm.
just so that fourth year, like to me, I don't know. I mean, it was fun and it was more relaxing than my first 3 years, but it
Yeah.
definitely did not strike me as like unnecessary thing.
Yeah. Was it kind of like a study year for you for the boards, or did you already write it by then?
So no, I'm in the process of studying right now. You have my books surrounding me. Basically here it's only offered once a year and it's in September.
Oh,
And
okay.
so when you graduate in like June, you wind up having a couple months, to study and prepare for it, and then you sit for it on September 14th. So
Wow.
I'm getting ready to do it now. I'm not super excited. I'm kind of like done studying, like I've
Yeah. That's kind of the mentality of whenever I got into residency. It was kind of okay, especially with psychiatry, which is a pretty unique kind of specialty that I'm very excited to kind of dedicate the rest of my schooling to things that I'm inherently passionate about. But in the States, that 6 months of neurology and internal medicine, that would be a slap in the face to me. How was that?
Good for the most part. I think it's very dependent on your senior residents that are going to be working with you on those services, right? Because you're not an internal medicine resident, you're not a neurology resident. So I think if those people are on your side and they understand like you're there to learn a few things about internal medicine, learn a few things about neurology, but you're not there to necessarily work as an intern on internal medicine or as an intern in neurology,
Definitely.
and so it can be really good that way. And they're usually happy to have someone who has psych knowledge. To be
Mhm.
honest, I can't. I would say like there's so many cases where there's a psychiatric component, whether it's somebody
Mm.
who just takes psychiatric meds or whether it's somebody who's actually having some kind of, psychiatric issue while they're hospitalized. So whether that's depression, right, or whether that's some type of delirium, or
Mhm.
you got major neurocognitive disorders that I think we're also well suited to treat and to consult on. So they do really appreciate you, I think, and it's a little dependent on who your
Yeah,
patient was. They appreciate it, what you can bring to the table.
definitely. And do you feel like you felt the same? Because I think I've heard that and I've also experienced it in kind of certain ways. And I think it, depending on your attitude, I was definitely kind of heavily interested in psych and passionate about it for a very long time. So kind of even throughout clerkship, sometimes if people would ask me what I'm interested in, they would kind of gloss over once I said psychiatry and be like, okay, you don't really, you shouldn't see that patient, or you can go home early kind of thing. Did you feel like you had some of that? But like I could have fought and said, hey, I want to learn a lot more, but I didn't.
So yeah, no, it's like interesting for me too, because when I first went to med school, I thought I wanted to be a general surgeon. I
Oh
had
yeah.
some, yeah, completely different, right, than psych, like totally off the wall if you were thinking psych. So I was pretty sure, like, I was like, oh yeah, I had some friends that were general surgeons, and they ran a bariatric surgery clinic here in the
Oh.
States. And I got to hang with them. I get to do some, hang out in the OR, see some cases, this kind of thing. And I was like, oh,
Nice.
I'm sold on this. I'm stoked on surgery. And it was my first clerkship. And by the end of it, mine was very long in comparison to most people's. I did 12 weeks of general
Oh.
surgery, which was terrible, absolutely terrible,
Hmm.
as a student, especially as a brand new third year medical student.
Oh.
And at that point, I was done. Like I was like, no, this is not for me. These hours are crazy. These people are like, they were all like really irritable. Like I think just the hours, the stress, whether it was the attendings or the residents, they all like were kind of just like burnt out already.
Hmm.
And I saw that and I was like, no, I'm not doing this.
Fair.
So
That
at
must
that
have been a complicating time though, eh?
Right. I mean, it's tough because you want to, and I had like zero skills at that point, right? Like I told you, I didn't really do like a
Yeah.
whole bunch of like stuff. I wasn't like in EMS or anything like that. Like so I didn't even know how to like suture or close up or whatever. So it took me a while to, kind of get myself ready for all that stuff. But,
Hmm.
by the end, I think like we had an understanding. Like I did well on my like shelf exam, which is sort of like your end of rotation exam that everyone has to take.
Yeah.
um, but it was just not an experience that I wanted to go through again, and certainly not a place I saw myself spending five plus years training
Hmm.
in. So my second rotation was psych,
Oh.
and that I fell in love with it 100% at that point. I always kind of knew psych was something I was interested in, but I didn't know, like, I saw it like a lot of other people see it, right? As like maybe this is like a lower tier specialty. It's kind of where people go if, they're not very good. That was always,
Hmm.
that was even told to us like at St. George's. It was like, well, you could apply psych if nothing else works out for you. Although that's not true now, I would say it's a little more competitive. But that was
Hmm.
the mentality. It was like, hey, you could apply psych, it would be fine. But I knew at that point like it was for me because I fit right in and I felt like I could do the work right away, which was different than my other rotations. Like everything else I did, I needed to like work at to be good at.
Hmm.
Psych just felt like really natural to me. Like I was able to like I got my psychiatric interview down, got my mental status exam down. I was writing H&Ps like for the residents really easily. Like it all just flowed the way I felt like it needed to, and that was different than other clerkships.
Definitely. I was interested. I did like a minor in psychology in undergrad, but mostly because the courses were a little bit easier and because it was
Mhm.
so interesting that memorizing just like biology, it actually made a little bit more sense and it was a little more fun for me. But going into medical school, I knew kind of like you were saying, I was always kind of people focused. It was all about the relationships, but I thought psych, I come from a medical family, so they
Cool.
were kind of cautious to me about kind of psychiatry in terms of taking things home and getting involved. And I'm sure there was an element of that respect kind of thing that it's like sometimes lacks. But as I got along, I was thinking maybe like GI or
Mhm.
oncology, where you have those long running disease courses that you'd actually have that rapport to build. And then I was a little bit scared of psych because that kind of attachment, that separation from the patient, you can't necessarily be your boisterous personality. You have to rein it in. You have to be a bit more of a blank slate. So I thought that that would kind of go against the reason why I went into medicine. But the more and more I had experience and the patient population and the opportunities outside, like education, like that you're doing with the YouTube series, it's a lot of inherently interesting things, and it just happened to kind of coalesce with the time that society is really taking a second look at the whole area too.
I agree with you 100%. I mean, for me, it's the most interesting of the medical fields. And I think about it like this. There's actually a really great book that I would recommend to you real quick while I'm sitting here. So I actually have it sitting in front of me. It's called The Perspectives of Psychiatry. Very, very good book. Um, and definitely worth a read because
you're not getting any kickbacks from that, Dr. Rossi, are you?
No. I push, right? I mean, if anyone wants to pay me to do these things, I'd gladly accept. But right now, that's just the love of the game.
Go on. Sorry, the perspectives of psychiatry.
Yeah, that's it. So great book. And one of the big points that they make in it is this idea of a mind-brain disconnect, right? There's this idea, this concept of the mind that we actually don't fully understand at all. We have really no idea what this really is. But then we have the sort of biological components of the brain, more of the way like a neurologist thinks about the brain and about the nervous system. And so that to me, like figuring out how to operate in that gray area and really like make a difference in a patient's life it might be the toughest job in all of medicine because you don't have the objective measures that other specialties have, right? You don't have the you have some neuroimaging, but you don't really have definitive neuroimaging studies. You don't have great laboratory tests that you can order. You're really relying on what you hit on actually right there before in the previous point, the relationship. And I personally think that that's like actually the most important component of psychiatric care. And maybe the biggest thing that helps patients get better is that having a great therapeutic alliance and a good physician-patient relationship. If you have those things, regardless of what medication you choose, regardless of what therapy modality you try to implement, I think you're going to have good outcomes.
Definitely, and I think it's also kind of something that's inherently motivating too. I remember some of my classmates kind of going through psychiatry. They were interested in internal medicine and surgery, and they made a decent point from one of our lectures in terms of kind of these diagnoses of anxiety disorders and mood disorders. And they were kind of wondering, why are we kind of learning about all these structures when we're going to throw an SSRI at them, regardless for a lot of things, which is a fair point from kind of that simplistic point of view. But for me, each case or each kind of diagnosis doesn't necessarily, it's very interesting eliciting those symptoms and it's getting the life story to put everything in context rather than just kind of a chart of symptoms and then what medications to address each. So that kind of humanistic part and art of psychiatry, I think, is the most pronounced in most of medicine, I would say. Like I can see the art in terms of technique for the surgical specialties in that way, but not something I am too motivated about.
Yeah, but I mean, you're right, and I think that's why you're hitting on another like really important point. I think is that some people view the field of psychiatry as like very easy, right? At least if you think about it from a purely biological perspective, it seems like very simple, right? If you have an anxiety disorder or depression, you basically get the same medication, and you could make an argument that you could close your eyes in whatever your favorite psychopharmacology book is, and run your finger down the page and land on a medication and it would be fine to just prescribe that medication and it wouldn't really make a difference, right? They're all kind of equal efficacy in terms of the SSRIs or SNRIs. We know it's only effective in about a third of patients, right? And maybe a third do really well, get remission. Then there's another third that do okay, and then there's like a third that don't respond at all, or respond very minimally. So a lot of people think that it's a simple field from that perspective, and that's why I think like here in the States we're getting a lot more like nurse practitioners, we're getting a lot more PAs like running to the field because it just like is first of all it's a good lifestyle which matters in medicine for a lot of people, but also that same perspective that it's somewhat easy, but I don't see it that way, and I think a lot of times like I was saying, people don't get better on the initial
Mhm.
medication. It takes some trial and error. It takes some art, right? You have to
Mhm.
have some art to your pharmacology, and you have to have some depth of understanding and be willing to get outside sometimes of the maybe FDA approved, medications, and be willing to experiment with things that are off label as well. So I think that's where you, as the medically trained psychiatrist, is going to have a great advantage if you dive deep enough into the pharmacology. There's many different ways to sort of manipulate it and get good at it, and I don't think it's as surface level as people may think.
For sure. And I think something you said before really struck me too, that the maintenance, first off, in kind of building the rapport to get that trust, to get to the kind of meaning and maybe the past behind some of the symptoms, but at the same time to keep patients motivated to, okay, fine, doctor, I'll try the next drug. Like I won't just kind of like not show up or kind of not trust the medical system in itself, because there's lots of times I remember it going through clerkship and even in my electives, you'd see, okay, previous diagnosis of bipolar and all this kind of stuff. And then you'd see a change to schizophrenia, all this stuff. And you'd think, okay, so one psychiatrist who's kind of trained the same as another would differ in terms of diagnosis for the same person's kind of symptoms that are similar, but it's not, the diagnosis isn't necessarily that important. It's more kind of symptom resolution. And for a time, that was tough for me to kind of think, okay, well, is it black or is it white? Like what's up and what's down? But it's really about the formulation and the continuity of evaluation.
Another excellent topic that we could discuss forever: diagnosis, the importance of diagnosis, whether or not my recommendation to you or to anyone who's thinking about psych as a as a field for themselves is to sort of think of these psychiatric diagnoses as fluid and evolving. And I would also say, don't ever trust a diagnosis that, even if it's another well-respected clinician that made it, including myself. I always try to tell like people I train with, my trainees, the same thing. Don't trust it, even if it's my diagnosis. You should always be evaluating and thinking about the symptom presentation and kind of putting it together and formulating your own thoughts on it, because it is very gray. Things do tend to evolve. Sometimes you see somebody once and you're like, oh, it's, yeah, classic depression. And then it might be like the 10th or 12th time you see him, and then you finally catch him in that like manic phase, and you're like, oh no, it's really been bipolar this whole time. So you've probably been doing this person a disservice, destabilizing them
Yeah.
the whole time with
Yeah.
antidepressant.
And I think that that's another element of psychiatry with that kind of art and that lack of objective measurements. You have to be okay with being wrong, right? You're not going to get to slam dunk every time and be always correct. Like there is an element of humility inherent in the practice, seems like.
Yeah, I mean, diagnosis, like I think partially what you were saying is definitely correct. Not to be too obsessed with the diagnosis, but I do think it's really important to get it right at some point. It doesn't have to be, like you said, a slam dunk right away, but it's very important that over time you evolve into the correct diagnosis. Because whenever you read a research study, right? Let's say you read the Katie trial, whatever, you're reading some of these big things. When they select those patient groups, they really do a good job of kind of weeding out all the people who don't fit the diagnosis. So the
Yeah.
medications really, like, those results are unique or specific to people with schizophrenia or people with major depressive disorder, not people with bipolar, not people with other disorders that maybe they've kind of weeded out when they're making their patient selections. So
Yeah.
it does become important eventually, but definitely being open-minded, looking at each case as, like, even if the person's been seen a number of times, because this will happen in your training. I think this is actually a good point to talk about real quick too.
Sure.
Um, when you're on the inpatient unit, when you're in the ED, you're going to come across like the same people over and over again. There's going to be, what some people might term frequent flyers, right? These are people
Hmm.
that just, like, they can't seem to stay out of the hospital no matter what you do.
Yeah.
And it can become tough for you as the trainee, because you're like, well, what did I do wrong? Like, why didn't this person get
Hmm.
better? I did all the right things, et cetera, et cetera. But even though, always reevaluating, always, rethinking that diagnosis when they come in that, second, third, fourth time, and saying like, okay, well, what was done and what could have been done differently, and maybe we're missing something here. So I'm really stressing that with my training, is like diagnosis and being really meticulous about the symptoms and making a correct diagnosis.
And did you feel like you had any kind of attendings through your psychiatry block or maybe senior residents that really kind of helped feed the fire for psychiatry once you kind of had that surgery switch? That must have been quite the whiplash transition.
A lot of it for me, and it's kind of like, I think it's kind of like choosing a place to train at, to choosing a place to do your residency at. A lot of it was
Mm.
just like, it was how I felt about it. So I don't know if it was any particular attending. It was more the mindset that I had, the feelings that I had going into it. I felt like, wow, like this just fits me. It's perfect. It's like it's what I like to do. I'm pretty good at it already, and I'm not even, I haven't even trained more than 6 weeks yet, but I feel like pretty comfortable already. And that I think was the most important thing. And after that point, when I did other clerkships, I basically told them, I'm like, I'm doing psych. Like I would
Yeah.
just like, I told them straight up, like maybe that was negative on me a little bit. Maybe some people didn't like that idea, but I think them knowing that, and I would tailor my stuff to it. Like for example, when I was in my OB rotation, I had to do like, you always have to do like a presentation or something
Oh
as a
yeah.
requirement. I did it on postpartum depression. So
Mhm.
I started finding ways to like incorporate psych into the other specialties and seeing how I could like continue to hone my skills in psychiatry while still completing the requirements for OB or pediatrics or whatever.
And in those opportunities too, like your passion will bleed through your work. You'll work hard at it. It's not necessarily as much of a checkbox that could help you in your career in the future. I did kind of similar things for those presentations, and also I think there's value depending on kind of the preceptor's personality. They respect people that are genuine. They know you're smart. That you got there. You don't have to kind of be, oh well, yeah, I'm thinking about being your protege in the future to every single rotation, right? They can see through that kind of stuff. So being yourself, there's a lot of merit in that.
Yeah, for sure. I mean, I think that's great advice too for people that are going through medical school. Again, kind of like what we were saying about when you make a decision on a specialty, you should really go all in on that. You should not, try to be half in, half out, or like choose backups. You should really just go all in on that one thing. And if you do that, and I believe anyone who does that will be successful. Because at this point, if you made it that far, everyone's smart, everyone's capable, right? There's not a huge difference in terms of those type of things. So it really just comes down to putting the work in, doing the right things to, get the right application put together for whatever specialty it is you're interested in.
Yeah, I think one thing I would say for in my experience, kind of going unmatched, I did only psychiatry last year, and I did like kind of like you were saying about the medical school. I did apply a little bit more narrow than I should have, and I didn't get that many interviews. But I knew that I was going to do another year of electives to do psychiatry because that was really my dream. But the second round, I did apply to family medicine. There's enough kind of mental health that I could have done their addictions and psychotherapy that I still would have kind of been able to feel fulfilled. And it's still a great job, right, compared to
Yeah.
any other alternatives. So it's not something I would kind of lose too much sleep about, but it would be regrettable to not try again. So I think it would be important to kind of be honest with yourself in terms of a backup plan that you don't necessarily have to spend so much energy crafting a complete parallel plan. But if you are very interested in one specialty, then you only change a couple of words in your personal statement to also apply to another place. There's not too much harm. But at the same time, I think it's important if you really believe that you would rather do another year and try for that same specialty again,
Mhm.
then absolutely don't kind of spread your energy too thin.
Totally, yeah, totally. And I agree with the point about family medicine. They do a great deal of psychiatry. They really do.
Mhm.
Most of our psychiatric patients end up seeking care at a primary care facility way before they ever come and see us. So that's
Yeah.
usually the starting point where somebody's going to initiate some type of psychiatric treatment. And a great way, and you're right about addiction too. So that's another good one. If you do family and you decide you really want to work with, sort of dual diagnosis patients where there's some
Mhm.
psych and some addiction, you could do like an addiction medicine. Like here we have ASAM or AAAP, which are fellowships in addiction medicine and addiction psychiatry. So that's another good way to kind of use that family medicine training in a way that gives you psych and addiction, if addiction's your thing, which I think it's a great field because there's a huge need for it, and it might be a better fellowship choice than child adolescent or something like that, even at this point, because there's just such a demand for addiction treatment.
Oh, wow. Because I was under the impression that child and adolescent is also in demand. Are you saying that addiction is just so in demand that it's higher, or is child kind of tapering off?
I think child is always going to be in demand, of course, but I know personally, like a majority of people who choose to do training and fellowship actually wind up going to child adolescent or trying for child adolescent. But my thought was like I'm looking down the road here. I'm thinking like ahead of the curve. I'm like, what is going to be the up and coming thing? And it's got to be addiction. Every time you turn around, somebody's talking about the number of overdose deaths or the number of the number of people who are seeking treatment who can't get it. It's just it's there. It's coming bigger than ever. But addiction population's tough. People have to
Yeah.
be ready for that. So and that's another place where like if you're not used to people not getting better like fast, that's a bad place for you because
For
the
sure.
the likelihood of relapse is just really high, even with good medication management.
Yeah. And I think that's the other kind of element that we kind of briefly talked about in psychiatry, about that. I don't want to kind of say perseverance because that sounds a little simplistic, but that kind of patience and that delayed gratification, kind of almost like the opposite of what they say people that are interested in surgery or something more kind
Mhm.
of immediately physically therapeutic is kind of see problem, fix problem, get out kind of thing. Whereas psychiatry is a lot more constantly evolving.
Exactly. I mean, you have to be that kind of person who can appreciate that. If you are looking to, like you said, fix somebody, I think surgery is a great place for you because you cut the appendix out and it's done, right?
For
For
sure.
all fix, better, sew up the wound and you're good to go. But for us, like it's going to take time. It's an evolving process, and like I said, I think it's the most difficult. I mean, it's the most difficult type of treatment to have to implement for people because we don't really oftentimes we don't know how these mechanisms and some of these medications even work. Like if you
Mhm.
look at lithium, for example, there's many different theories about why it can be helpful in mania and why it's good for bipolar and why it reduces suicidality. But there's not a definitive mechanism. It's still very unclear. It works, we know that.
Exactly. It's almost
So
like a reverse working. We know it works, and then we're just kind of like, okay, let's just keep using this kind of thing.
Right. I mean, and that's all the medications in psych. And I think also in psychiatry, you're dealing with one of the things I ran into. I should just bring this up briefly because it's
Absolutely.
definitely it's important for people to know when they're coming into the field. Is like it's the only field I'm aware of in medicine that has an anti-movement,
True. That is
right?
true.
I mean, no other, I feel like no other medical specialty has the same type of like apprehension from the patient perspective that we have. Like
Hmm.
you really, and I find this interesting, like working on the YouTube channel, this is where I see a lot of this. There's like, people are very interested in the medication, but at the same time, they don't want to take medication, right? They're very interested in
Yeah.
knowing like about it, and they'd be very happy if it like was a magic bullet and fixed all the problems. But they're also at the same time like they're conflicted, right? To use a psychoanalytic type of term, they're conflicted. In one hand, they
Mm.
want the medications to work and they want to take them, but at the same time, they also like are very apprehensive about and don't want any part of medication. So it's a very weird thing. And then there's this idea, that floats around that all these medications are harmful. They've never done anyone any good. And we as psychiatrists are like sort of perpetuating this idea of harming people for our own like
Hmm.
personal gain or benefit or whatever, our own personal like, interest, which
Yeah.
I find is incredibly ridiculous to say because everybody I've met in the field and worked with I think has always wanted to do well for patients and has always wanted to help people get better. It doesn't always go that way, right? I mean, it's not always perfect, like we talked about. But the ultimate goal, I think, is always good intentions. And even if you read about the history of psychiatry, I think whether you look at
Yeah.
asylum medications, the intention was always good. It was always to
Hmm.
do better for the patients. It just didn't always go that way. And so this was the idea that was prominent. This is what people thought would be helpful. And it turns out it wasn't. But I think you could find that in all branches of medicine, to be honest, if you look for it.
It's true. And especially with that kind of bias of hindsight, right? We look back and we're kind of like, oh, we were doing this and that to kind of manic people and to people suffering from psychosis. Like, how could we have ever thought that? But we didn't even know what those terms were necessarily at the time. We didn't know what was going on. And plus, we all know kind of the big bucks isn't in plugging the big pharma. It's in the perspectives in psychiatry out now on the bookshelves. Right, Dr. Rossi?
Yeah.
Yeah.
Look, I'm as skeptical as anybody about the idea of like putting all of your marbles in, in medications and everything, putting everything in, pharmaceutical companies to come up with these things. If you really look at the field of psychiatry, the medications haven't evolved much in the last like 20 or 30 years, right? They're kind of been the same. There haven't been many like great new. We're starting to get some good new mechanisms, but it's only beginning now. It's been years of like kind of the same stuff over and over again, recycled and repeated. So there hasn't even been like a lot of, I guess, excited researchers in pharmaceutical development that what really speaks to us as psychiatrists and to our patients. But I'm hopeful for the future because I think that's what you have to do. You have to take an optimistic viewpoint of it and say like, and we should not, as psychiatrists, do ourselves the disservice of sort of hating on our own field or doing those. We should be saying like, look, well, yes, what we do is difficult. It's not perfect. It's not an exact science. You might say that all of medicine is pseudoscience at best, right? I mean, psychiatry maybe falls a little bit more in that pseudoscience-y area, but I think you could again make the point that a lot of times when I was on internal medicine, is it COPD exacerbation or is it CHF exacerbation, right? It was like not really 100% clear. You would probably like treat one or the other, and if the person got better, you're like, okay, great, yeah, we got it right.
Yeah, exactly.
It's still a little pseudoscience. It's not definitive. It's not perfect. So I think that's an important point to kind of always remember is that like, yeah, we're not perfect. We're doing the best we can with the tools that we have.
And I think you kind of with that public facing element, like you mentioned, it's important to have the transparency and kind of be honest about what we know rather than kind of ride on the clout of the titles and things. Because then once there's like holes poked in, then whole distrust on the whole industry and all that kind of stuff, which is some things with the anti-psychiatry movement, which is interesting because a lot of it is that historical lens like you mentioned, and I only really see it on social media, but I may have a larger presence kind of in the States than Canada as far as I understand.
Yeah, I mean, it exists. Well, the only reason I bring it up is because I've since come into contact with some of these people working with the YouTube channel, and I have it. And it's not like I have a huge following. I have a small following of people. I don't have many subscribers on the channel as of now, but I've already gotten a fair share of people who like literally like would just continue to comment on the pages about this stuff. It's like fine. Like I'm open to like a comment about it being on there. I'm fine with that. Like you want to say your piece once. That's great, but don't do it on like every single video because then at that point,
comment, dude.
Yeah, it's just spam. It's ridiculous. It's like, and that's not what we're going for, right? That's not the message we're trying to promote. And there's certainly places where like you said on social media that exists, and there's plenty of like-minded people that would be in agreement with those statements. I think what we are trying to do, both of us, is kind of put a new face to psychiatry in a way, right? Kind of give a new spin to the field, make it more accessible to people, make it more open, be transparent about what, like you said, what we know and what we don't know, and really try to add value to people's lives. That's the ultimate goal.
Exactly. And it's just like you said, historically, it's all with the good intentions, and that's kind of what we can say our piece about. And what people can ascribe after the fact, we're not really in control of that.
Yeah, I mean, I think anybody who talks about those things should definitely read the history, and there's good books on that you can find as well. I've been reading one over the summer. That's been a really kind of good experience just to kind of see. I mean, it's a new field. We're in a relatively new field. And yes, some of the things that were tried and attempted were not successful. But again, I think you could look historically at all of medicine and find those examples of surgeries that didn't work the way they were supposed to, or procedures that didn't go the way they were supposed to, and caused harm. I think intent matters. That's something that's missing in society these days. There's something to be said for intent. If the intent is good and that's what you're trying to promote, like that counts. To me, that's valuable.
Yeah.
These days it's not though, right? It's kind of hard.
Yeah, it is definitely a difficult time for that kind of principle to stand and be defensible in some areas. But actually, that does bring up a good kind of classic case of the ECT and One Flew Over the Cuckoo's Nest. And I saw a comment recently about someone saying, "Oh, they used to do barbaric stuff like ECT, like just in general for medicine." And I was kind of like, "Wow, like I thought we would already close that circle and come back and seeing the benefit, at least in some cases, of course." But it's really hard to get rid of those beliefs once they kind of stick, right?
So I know I'm like probably running short on time, but I could say like I do a lot of advocacy work, right?
Mm-hmm.
And one of the things that I take from advocacy that I think you could take from these examples of like of One Flew Over the Cuckoo's Nest or popular media and why it's important for us as psychiatrists to kind of speak out against those things where they don't depict the field correctly is that those stories matter to people. The stories are more meaningful than any statistics you can blurt out, right? Let's say you're meeting with a representative or something in in the government, and you're going to discuss things about about a particular bill that you're trying to pass that's going to help patients in psychiatry. They're going to want to hear some of that statistic stuff, but if you have a really good case or person you can point at, you can say like, let me tell you this story about a patient I treated. Let me tell you why I think this something like this would have helped this person if it was available. That's going to be way more impactful on that person's decision to support or go against that bill than anything you say about the facts. Like, cool, like nobody cares about the facts. They care about the stories and the meaning behind them. So I think that's where like popular media hurts us in a way because the stories, I mean, they resonate with people. They're impactful, and you got to be careful how that's depicted.
And unfortunately, sometimes those experiences are the exception to the rule, yet they stick. And it's not to invalidate that they occur, but for sure it might be overrepresented in the conversation.
Yeah, definitely. I mean, I actually wrote about it. I had a Kevin MD article that I wrote about, and I said that One Flew Over the Cuckoo's Nest ECT scene might have been the single most detrimental scene in all television or movies for the field of psychiatry.
Yeah, like it's hard to think of another that resonated so powerfully.
It had that big of an impact on people and still does to this day. So I think dispelling some of those myths about ECT and how the process works and everything is very important as well. So, and that's what you're doing here. That's what I'm doing. We're trying to kind of show people like, all right, we're going to educate you about how this stuff really works and how this stuff really goes down. And it's not going to be the dramatized, television or movie version.
Exactly. Just kind of the transparency is key in getting some of that public trust. But we're just about wrapping up our time here. Is there anything that you wanted to kind of tell the audience about your Shrinks and Sneakers channel and anything else that you wanted to promote or talk about?
Yeah, I mean, I'll leave the audience. I know it's mostly people who are training or thinking about training in psychiatry. That's the kind of the group we're going for. It's certainly possible if a learning disabled guy like myself could get through all this and eventually obtain a position and finish the training, then I think anyone can. So I always remind people that it's never too late, and it's also something that you shouldn't give up on too soon. So from that perspective. But yeah, sure. I mean, Shrinks and Sneakers is small. I pretty much do most of the stuff myself. I did have another resident that was working with me on some of the content, but she doesn't really put that much time in and hasn't in a while. So it's been mostly just me doing things that I like talking about, and I'm super passionate about psychiatry. So I can promise anyone that comes and joins the community that they'll get the personal responses from me. I'll think everything through, and I'll give my best understanding of any topic, and I'm willing to cover whatever people are interested in.
And for sure, I can vouch for that. I've seen it in action, kind of making videos on the comments from a lot of learners have been very interested. It's a great information resource. And I think just to echo what you were saying, kind of both of us are evidence that maybe there isn't necessarily a typical type of story for any type of person in medicine, but in psychiatry as well. You don't have to be that kind of straight A's, high school, straight-laced type person to enter the field, don't count yourself out too early.
Yep, excellent points for sure. And I'm always happy anybody who can reach out at any point. Always happy to help in any way I can.
Excellent. Well, thank you so much, Dr. Rossi. It'd be great to have another episode maybe down the line once the big boards are down, but good luck with that as well.
Yeah, no, I appreciate it. Thanks for having me, Ron.
My pleasure. Take care now.
Take care.